What else can you do? You can use innovative technologies. And technology is such now that there's so much you can get. So much. It helps you to improve the efficiency and the effectiveness of the monitoring and evaluation that you need to do. You can use phones. If you have a population where they have phones, cell phones, you can use your phone on their phones to reach out to them, to monitor and evaluate what's going on. You can use WhatsApp for those who have Android phones and who have downloaded WhatsApps. You can use short message services, text messages, and use technology to improve the effectiveness of what you're doing. We don't have much time. I would have gone to town about the technology we are using in the University of Port Harcourt Teaching Hospital, where we have our antenatal WhatsApp group. Right now, we have over 600 women in that WhatsApp group, and we use it to monitor them, listen to them, get feedback, know what's going on, and know how we can improve our services, as well as how they, the end users, can improve their behavior to ensure that we all get better maternal health services. Can agree with me that sometimes it's not just you who's trying to deliver services. It's not just you changing that will make things well. Sometimes the person you're delivering services to, if they are not behaving well, then they negatively impact on the outcome that you're supposed to get. All right. So I've written here again that another thing we need to do to ensure that we're delivering good services and that we're monitoring and evaluating what we're doing is to conduct regular evaluations. It's not just a one-off evaluation. You don't just do once and say, okay, oh, everything is fine, they're doing well, and that's it. No. Or just come once and say, oh, they are complaining of mosquitoes. Okay, let's eradicate mosquitoes. Once we eradicate mosquitoes, they are okay. You could finish eradicating mosquitoes and then they tell you there's another thing that's the problem. But because you're not conducting regular evaluations, you wouldn't know. Okay? So regular evaluations are essential for tracking progress, for identifying challenges, and making necessary adjustments. These evaluations should be conducted at regular intervals to ensure that the interventions remain relevant and effective. I hope I'm communicating. All right. So yes, the next thing that we could do, or the next thing that we should do to ensure to improve our monitoring and evaluation processes is to provide feedback. Okay? You provide feedback to stakeholders. Your stakeholders could be the health workers who are delivering services. Your stakeholders could be mothers, your pregnant women, could be community leaders. All right? Providing feedback is essential for promoting accountability and encouraging ongoing improvement. Remember, we're talking about maternal health development. We want to improve what we're doing. And there's no end to improvement. Improvement is a continuous thing. So to promote accountability, to encourage ongoing improvement, we must provide feedback to stakeholders, okay? Feedback can also help us to identify areas that need improvement, okay? It can also help us to recognize areas of success so you know where you're doing it right, all right? So feedback is important, and feedback is a two-way thing. You are providing feedback, then the people who are receiving services are also giving you feedback, okay? I'm looking at the time now. I see that we don't have much time. I had 4 slides after this left, just talking about patient experience, feedback among staff that we are currently seeing at the University of Port Harcourt Teaching Hospital, okay? Where we have the antenatal women that we look after, the postnatal women, the women intrapartum, okay? So we're asking the patients their experience. How do you find facilities? Is it clean? Is it satisfactory? Do the nurses show you kindness? Do the doctors explain things well to you and so on? You know, how long do you wait before you're seen? All these things affect how they receive the healthcare services that you're trying to deliver. And if you're not doing well, if you don't ask, You won't, if you don't get feedback, you won't even know where you're not doing well. So feedback is really important, okay? Those are my UPTH mothers. I do some sort of lots of pictures with my mothers, all right? So next, even from staff, you need feedback from staff. Okay, so in your little corners, if you have people working with you, you need to appreciate those working with you, because your human resources is your greatest resources. That is what you have that is unlimited. Funds are limited. Money is never enough, but the human being is there. Therefore, you need feedback from your staff as well to help you know how to better take care of your staff, okay? All right. All right. So this slide shows that as you monitor and evaluate, you would see where there are changes. And from this slide here, you can see that from our latest maternal mortality ratio for 2022, we have a steep downward trend compared to when we started in 2013. So this is a 10-year maternal mortality ratio showing monitoring and evaluation, what we are doing and how it is impacting on our services. And so when you do all these, what else? Sustainability and scalability, okay? You have to sustain the efforts right from the onset and ensure that your M&E activities are integrated into the overall program design and budget. Mind you, if it is not budgeted for and it's not done, if you didn't provide that this would be done, then it never gets done. Okay, so from the onset, start monitoring and evaluation, okay? And seek opportunities for partnerships and collaborations to leverage resources and expertise for sustainable M&E efforts. If you implement all these things, it is possible to improve monitoring and evaluation for sustainable maternal health development. This in turn can lead to better health outcomes for mothers and their newborns, helping to create healthier and more resilient communities. Thank you so much. I think I'm going to stop here. All right. This is a summary of what we've been saying. Thank you so much. Bye-bye, everyone.
Thank you so much. Thank you so much. Thank you so much, Prof. I kept on jotting and nodding my head, because what I was hearing today, I've never heard them before. Even when I go to the hospitals, I never knew that they are supposed to treat the patients well. I never knew that they are supposed to be friendly, because most times the doctors and nurses, they'll just come and say, let me just do my business and just go. You just go, let me go to the next person. I don't know, they're supposed to be friendly, they have to be nice and all that. Thank you so much. Thank you so much, Prof. So we are going to, I don't know, do we have any question? Any question? Do you have any question for Prof? Anyone? Please raise your hand up or put your question in the chat box. Any question for Prof? Okay, in the absence of any question, probably a question may come in. So we are going to the next agenda, which is the second presentation. This presentation will be done by Dr. Borowa Azabi. So he's going to be talking about the knowledge, attitude, and practice of adults towards primary health care services in Alimosho local government area, Lagos. Let's please welcome him. Welcome. Doctor, are you around?
Hello, everybody. Good day.
Welcome.
So
Doctor.
I'm trying to share my screen now. Can you permit me to share my screen?
Yes, you should be able to share your screen.
I've stopped sharing so she can share. Thank you.
Yeah. Thank you, Ma. Thank you so much, Ma.
Okay, I guess you can all see my screen now.
Yes, we can.
Yes.
Okay.
Yes, we can see your screen.
Okay. Good day, everybody. I stand on all existing protocol. Good day, M1 presidents, organizers of Safer Hands Initiative, senior colleagues, junior colleagues present. I'm Dr. Borowa Azabi. I'm the founder of Rebecca Foundation. And today, happy International Maternal Health and Rights Day. I'm very glad to be presenting my research to everyone here present today. It's really a privilege. I'll always be grateful to M1 and Safer Hands Initiative for this amazing opportunity. So going straight to it, I'll be presenting knowledge, attitude, and practice of adults towards primary healthcare services in Alimosho local government area, Lagos. So this was an NGO community-based research that was done to improve primary healthcare in Nigeria. This project started over a year ago during my NYSC year, and the burden, what brought about the conception was the fact that I was privileged to be posted to a community health center, primary healthcare center at Alimosho, and I saw the problems, the challenges primary healthcare system faces on a regular basis in Nigeria. I'll be using this outline in this presentation. Introduction, I'll state my objectives, the methods, my results, my conclusion and recommendations, and of course, my references. So going straight to it, with the accrescent population of Nigeria, a country with doctor-patient ratio of now 1:9083, the need for public health coverage cannot be overemphasized at this point in time. More so, the increase in the brain drain from Nigeria. It is very important that we resort back to primary health care. Primary health care is essential health care, which has its basis on practical, scientifically sound, socially acceptable methods and technology universally acceptable to all through their full participation at an affordable cost. So take note of some keywords there: universally accessible, full participation at an affordable cost. And this is the vision of WHO. WHO has projected that primary health care is the future of medicine. Primary health care is key to achieving sustainable development goals and reducing the burden of presentation to tertiary health centers, reducing the burden of maternal mortality, childhood mortality. Today, International Day of Maternal Health Rights. It is very important that we look into this vital subject. How far have we gone? So far, since its inception, primary health care has barely achieved the purpose of its conception in 1978. Primary healthcare system is still where it is today. While during my NYSC, while I was posted, I saw the challenges of lack of essential drugs, poor community participation, dilapidated health infrastructure, poor government support. And this is quite sad because WHO has projected that primary healthcare care is key to achieving sustainable development goals. So this calls for a reflection. What are we doing? Like the previous presenter mentioned, you do your bit, I do my bit, you do yours, and we see how we can make things better from what it is now. And I hope that we all play our part to improving primary health care center. Like you all know, antenatal care, immunization are key components of primary health care. And all these are very important. So these are my objectives. These were the objectives of this study. I did it to determine the knowledge of PHC services, assess the attitude towards PHC services, identify practices of people towards primary healthcare services, and furthermore, seek opinions on ways PHC services could improve to encourage community participation. So like I said, it was an NGO-based community outreach. My foundation, Rebecca Foundation, we partnered with Safer Hands Initiative. Thank you so much, Dr. Agoy, for all your mentorship, all your guidance, and all your partnership. So we did this. It was part of a project titled Revamping the Primary Healthcare System in Nigeria. and participants were adults that attended a series of outreaches we organized at the time and were willing to participate in the study and were residents of the community of Alimosho local government area, Lagos. A total of 80 participants were enrolled. Data analysis was analyzed using EpiInfo software. So these were my results. Regarding the knowledge of primary healthcare services, more than half of the participants knew about access to sanitation and hygiene, 52%. Then also greater than 3/4 of the participants knew about antenatal care services and first aid services, basic health care education, family planning 96%, immunization 96%. So they fairly had a good knowledge of the services of primary healthcare center. But regarding the visits to primary healthcare center, 20% had never visited the primary healthcare center in their area. 50% reported that they rarely visited, and 30% visited regularly. On the level of satisfaction with PHC services, it was reported that about 8% were fully satisfied, 56% were moderately satisfied, and 16% reported poor satisfaction. So despite the good knowledge, but we found that there was poor satisfaction and poor practice of visiting the primary healthcare center. Now, on the major factors that discouraged their use of the PHC services, we found out that expensive cost of services was 87%, then limited number of services, 19%, unskilled staff, 18%, poor infrastructure, 16%, and limited operating hours, 10%. A number of them wished that the primary healthcare services could be for 24 hours, which was not what was attainable. Most PHC centers in Nigeria closed by 4 p.m. So these were some of the factors that they claimed discouraged them from visiting the primary healthcare center. Regarding factors that encouraged them to use the PHC, we found out that good relationship with the staff. Some of them reported that members of the staff were nice to them. Few of them, 25%, reported that they received prompt care at the primary healthcare center compared to going to the tertiary centers. 24% reported that they received affordable cost of the services. 14% reported that PHC centers was of close proximity to their residential area, encouraging them to use the primary healthcare center. Only 1% and 3% reported the quality of service and clean environment, respectively, as encouraging factors. So furthermore, when we asked them about areas they wish the primary healthcare could improve on, 39% reported they wished there could be reduction in the cost of services. Remember, in my definition of primary healthcare center, I mentioned about the important concept of affordability in healthcare. Then 19% talked about increased number of services. Some complained of limitations in the number of services that was rendered in the PHC. Construction of standard infrastructure, about 15%. Also availability of skilled staff, and 11% reported increase in the operating hours. So in conclusion, this study showed that respondents had good knowledge of PHC services, whereas they also demonstrated poor utilization and satisfaction with PHC service. This indicates that diversion of resources and revitalization of PHC is needed to take primary healthcare system to its zenith. So this is a time for us to look back at how far we've gone since its inception in 1978, despite all the efforts that were done, efforts such as the Ransom Olikoye, his efforts to strengthen the PHC system, the Bamako initiative, the drug revolving fund. We discovered that PHC is still where it is because of certain factors that have caused limitations in the development of PHC. So this is the point for us to look back at where we are now and re-strategize get ourselves involved in more public health awareness, more public health knowledge involving the government, relevant stakeholders to improve the primary healthcare system in Nigeria, thereby improving maternal health care, child health care, and other important components of primary health care. My recommendations are more government and political support. We should all encourage this, including adequate budgetary health insurance and optimal maintenance of available infrastructure and compensation of healthcare workers to improve primary healthcare center, and also reduce the rate of brain drain by improving the structures and opportunities available in our country to make things better and encourage healthcare professionals to stay and improve the health and well-being of Nigerian citizens. Emphasis should also be made on the core components of PHC, including community participation, accessibility and affordability of healthcare, community participation.
Sorry, doctor, time is up. So sorry. So sorry, ma. Sorry.
Yeah, thank you very much.
Thank you so much.
Thank you.
Okay, thank you so much. You can also share your email address on the chat box in case of anyone that wants further information or knowledge. You can share with us via email. Thank you so much, doctor.
Thank you.
I truly appreciate. My apologies for cutting you.
No, it's fine.
For the interruption. Thank you so much, doctor. Okay, now we're going to the next agenda of today. I'm going to, I want to call on my co-moderator, Miss Olabisi Deborah, to come and anchor the next agenda. Miss.
Thank you very much. Thank you so much. I'm standing on the existing protocol. I'm going to be citing Dr. Omotunde Busayo Odanye, the State Program Manager for the Challenge Initiative, Lagos, Nigeria. She's a medical doctor with ample clinical and reproductive health programmatic experience. She graduated from the College of Medicine, University of Lagos. She has a master's degree in public health from the University of Essex, United Kingdom, and she is certified in program management by University of Washington, USA. She's a member of the Association of Public Health Physicians of Nigeria, Lagos chapter, an innovative public health professional with a drive for advocacy and creating an enabling environment for positive behavioral change amongst different categories of stakeholders, with more than 10 years experience in key public and private stakeholder engagements. Our mission is to contribute to improving the reproductive and general health of the populace through upholding evidence-based decision-making, quality healthcare service, system strengthening, demand generation, and policy making. Please help me welcome Dr. Omotunde Busayo Odanye. Thank you very much.
Thank you very much. Good afternoon, everyone.
Good afternoon.
Just a minute, I'm trying to share my screen. Please, can you see my screen?
Yes,
we can,
ma'am.
Okay. Good afternoon, everyone. Thank
Good
you
afternoon, ma'am.
for the introduction, and I appreciate Safer Hands Initiative for this laudable summit. It's a pleasure to be here. I acknowledge my senior colleagues. Thank you, Professor Ogu, for the presentation. I acknowledge the speakers that have spoken earlier and all stakeholders listening. It's a good afternoon here in Nigeria. I will be speaking on monitoring and evaluation, an essential tool for maximizing maternal health interventions. This is supposed to be like an engaging session, like a mini training. However, I need to state that we may not have all the time to do justice to the topic. I just want to encourage us to, beyond whatever we discuss in this few minutes, let's go ahead and learn some more as we also learn during this presentation. Thank you for your time. I'll be following this outline. First of all, monitoring and evaluation is every stakeholder's responsibility. From the leadership to the clinicians, to the researchers, partners, CSOs, providers, M&E officers, record officers. Monitoring and evaluation is everyone's responsibility because a lack of it or a functional M&E will affect all of us. Yes, either we are part of the M&E team, or either we're on the receiving end, or maybe our relatives. So it is all our responsibility. Though our roles may differ, we all have a role to play in monitoring and evaluation. For this presentation, I'll be using the word M&E interchangeably with monitoring and evaluation. Particularly for interventions targeted at improving maternal health, M&E is crucial. Why is it crucial? The care of a mother is in a continuum. She is in a pre-pregnancy state today, then she moves into pregnancy, and then to the period of childbirth, and then to the period of she moves into the postpartum period, and then she's back to the pre-pregnancy. This shows that the mother is a dynamic individual, continuously evolving, every phase having its own risk, requiring timely response as need arises. Our target audience for maternal interventions are a vulnerable part of our population. The value of motherhood cannot be overemphasized. The value of motherhood to the family, to the community, to the nation cannot be overemphasized. And the loss of a mother affects us all. Therefore, M&E maternal interventions is not merely a technical good-to-do exercise, but it is a system-wide intervention in itself, useful for local decision-making. I have here a framework for healthcare interventions to address maternal morbidity. If you look at this chart, you will see that a lot of interventions can come out from either the period of pre-pregnancy, antenatal, postpartum, the health generally, even from non-communicable diseases interacting with the integrating non-communicable diseases into the health of the woman. You can realize that that individual also has all these components. Okay, so because a woman has a non-communicable disease does not mean that it stops when she gets pregnant. It's an add-on. Okay, it's an add-on, and this woman also has a right to her health, irrespective of her current medical history. Also, a lot of interventions can come at the community level. They can be at the facility level. They can be, as like Prof said, they can be small but effective. They can be large scale, yes, nationwide, yes. For example, if you look at our NDHS, maternal mortality ratio, NDHS 2018 says it's 512 per 100,000. Women have an average of 5.3 children. 1 in 5 teenage women are pregnant with their first child. 1 in 5 teenage women are pregnant with their first child. Our CPR is 17%. That's our contraceptive prevalence rate. 39% of our women deliver in the facility, 59% at home. No postnatal care in 56% of delivered mothers within 48 days of delivery. Looking at the NDHS 2018 alone, we can see a lot of issues that we can design interventions for. So what is monitoring? Simply an ongoing routine collection of information about an intervention in order to measure progress towards results. Simply put, you design an intervention to solve an issue. There must be an ongoing routine collection of information that tells you that you are on the right track to your goal. It is routine tracking of your interventions activities. It is not safe to wait till a year or to the end of your intervention. Say it's a project for a specific period of time or a program that is running steady. You can't wait for such a long time for a vulnerable population as motherhood to determine whether you're getting to your goal or not. That is the importance of monitoring. You need to have indicators, which are measurable statistics that tell you real time that you're going towards your goal. I have a case study here. Let's look at it together. It says, an intervention is designed to improve the prevention of malaria during pregnancy. And one of the activities include distribution of insecticide-treated nets. How do we monitor? I decided to use this simple case study because I know that we have a wide audience. I know my senior colleagues are here also, yes. But I know we have a wide audience so that we can all follow together, okay? So this study is basically to prevent malaria. That's the goal during pregnancy. And one of their strategies is to distribute insecticide-treated nets. The question is, how can we monitor? I will have suggestions on the screen. Number of insecticide-treated nets distributed monthly. So that is in a logbook. That information goes continuously. Secondly, number of pregnant women who received insecticide-treated nets monthly in the facility records, documented regularly. Also important. Why are these questions crucial? They will give you timely response if there is an issue. For example, you look at question 1 and you know you procured and provided 2,000 nets. And your logbook of distribution says 20 distributed. Or number of pregnant women who receive nets are 200. And you can see that the number of antenatal care services provided, the women who attended those antenatal clinics are up to 2,000. That means there is a gap. You can quickly intervene. That is the importance of monitoring. Okay, so these interventions are being, so this intervention, this monitoring being executed guides your intervention. And your intervention also guides the monitoring, which means that your intervention is the one that determines the indicators that you will monitor. At the same time, when you have your answers to the questions that you use to monitor your activities, then you do what? You use it to influence your intervention. So this is me telling you that when you design your intervention, no matter how small your intervention is, break it down into a set of activities that are necessary to achieve your goal. Then you design one indicator each to track each activity to ensure that each activity is being carried out as planned. Let's consider case study 1 again. If monitoring now reveals that most pregnant women were not receiving these insecticide nets, it prompts a deep dive that further guides your implementation. Let's think this through. Are the nets sitting down somewhere in the shelves? Or the trained health workers, have they left the facility? Or are the women refusing the nets? Or is there a documentation problem? An answer to all these questions will tell you what next to do in your intervention, rather than procuring more insecticide-treated nets. For evaluation, evaluation is an assessment of the changes that have occurred as a result of your intervention or program, a measure of how well the goals of your interventions have been met. Let's look at case study 2. An intervention is designed to reduce maternal mortality. And one of its strategies is active management of third state of labor. You know, we have established that intervention can be at the facility level, it can be at the community level, it can be a nationwide program. It's okay. How do we monitor this intervention that is set to reduce maternal mortality by active management of third state of labor? How do we monitor it? Don't forget, this is monitoring now. Monitoring now. That is tracking your activities. First question can be the number of women who receive uterotonics. For those of us who are not clinicians, uterotonics commonly, the one we know commonly is oxytocin. It's one of the ways we use to manage third state of labor, okay? Then you can also ask the number of providers who are trained on this procedure, and then the rate of stock out of the uterotonics. These three questions will tell you steady if you're on the right track to achieving your goal or not. But for evaluation, the question now will be, at the end of your intervention, what is the percentage decrease in the number of women who had postpartum hemorrhage in that facility? Because if there is proper management of third state of labor, we expect that incidence of postpartum hemorrhage will decrease. Another question you can use to evaluate is percentage. Another indicator you can use is percentage decrease in the number of women who died from postpartum hemorrhage per month.
I'm sorry for the interruption, Dr. Kemi. Dr. Omotunde, sorry for the interruption, but you have 5 minutes more.
Okay.
Please. Thank you.
So I was almost saying that I have to rush. Okay. So comparing monitoring and evaluation, monitoring is ongoing. On the other hand, evaluation is at specific points during your intervention or after the intervention. For monitoring, it is through routine data sources, such as our health information system, which is our HMIS tools, our service records, existing reports, while evaluation requires collection of additional data. Monitoring is tracking progress for timely intervention, while evaluation is assessing outcomes and changes. Monitoring is by you, the implementer, you and I that are involved in implementing that intervention. We are the ones monitoring because we don't want to wait till things have gone out of hand. We want to maximize our intervention. We want to maximize it and ensure it is effective. So we are the implementers. We do the monitoring, but evaluation will require external evaluators. These are just importance of M&E. Provide feedback on progress made, enable informed and timely decision-making, improve strategic planning. You can allocate resources adequately. You can establish your priorities. It will provide evidence that your intervention has worked. It is also a quality improvement tool. And very importantly, it's an advocacy tool that can generate information. You will use it, you can use to mobilize community stakeholders and inform policies. These are various sources or platforms for M&E information. These are more indicators for maternal health interventions: maternal mortality ratio, skilled birth attendants at birth, postnatal care, antenatal care coverage. These are challenges you can face when you're trying to monitor and evaluate. Limited resources, tendency to collect relevant data, poor quality data, lack of feedback to key stakeholders, underutilization of the data, duplication of efforts, or a weak health information system. Best practices. Please note, when you develop your M&E plan at the level of designing your intervention, aim at quality data collection. If not, poor data, poor M&E, poor maternal health intervention. Conduct routine data review analysis. Provide feedback. Let your decision-making be data-driven. Engage the private sector, depending on your intervention. Drive coaching and mentoring for proper documentation. Focus on effective and efficient ways to get your M&E done. In conclusion, the health of women are critical for global development. However, information and data on measuring countries' progress are limited, given the variety of challenges of measuring care around the time of birth. when most maternal deaths and morbidities occur. To achieve the ambitious goals in the Sustainable Development Goals and to achieve universal health coverage, quality data on births, deaths, causes of death, and coverage of life-saving maternal health interventions are critical. Monitoring progress to our goals and evaluating the impact of our interventions and actions are essential to improving performance and maximizing our maternal health interventions. Thank you very much for listening.
Thank you so much, Dr. Omotunde. Thank you so much. That was very insightful. That was amazing. Thank you so much. I don't know if there are any questions. Are there any questions? M1 Lagos have a question. Please unmute yourself and ask your question. Thank you.
Thank you so much to our speaker, that is Dr. Donya. Thank you for the very lucid presentation, and also to the earlier speaker, Professor Ogu. So this question is like to both speakers, but more to Dr. Odonya. So because, you know, a lot of us work in the community, and when we work in the community, like a number of the organizations work in the community, so people do different type of intervention, you know, all at the aim of improving maternal health. We have a lot of non-governmental organizations doing different things. Most times they do some form of maybe health education, health awareness, health screening in maybe schools or in community. And because maybe they might not have the know-how, or they might not know that, oh, monitoring and evaluation is as important. So I want to ask, like, what are the quicker ways, or is it quicker ways now, or what are the most effective, easily accessible, or something that's easy to do that could be used to monitor and evaluate those interventions that are done by maybe organizations that do not have enough money to start, you know, planning ahead, maybe getting an M&E officer, or printing out questionnaire to, you know, do thorough data collection. But they are having a program, and at that point they realize that, oh, some form of M&E needs to be done. What are like the quick, easy, effective ways to do M&E? I don't know if you understand my question. Thank you, ma.
Should I go ahead? Should I go ahead?
Yes, please.
Yes, please.
Oh, okay. Thank you for your question. Okay, so it is clear. I understand what you mean. Monitoring and evaluation can be cost intensive many times, but not necessarily. So because it's a community level intervention, it's likely to be intensive. How about at the point of designing the intervention, the team needs to sit, okay, and decide amongst themselves and say, how best can we know if we are making progress? I'll give you an example. Our intervention is to get women to access family planning services from the facility. So our job is to go into the community, mobilize people to get services, okay? So at the point of designing, because it is a community-based activity, you don't have to do anything cost intensive. Photocopy, design basically number of women seen daily. We call that reach. For example, number of women reached daily. All right. Then number of women who agreed and were referred to the facility daily. And then number of people who eventually go to the facility daily. I expect that such an intervention would have a link to a facility. That is when the intervention is complete, okay? So you have a piece of paper that you give the person you have spoken to, and the person drops it at the facility. So what happens? You get to the facility, whichever facility has those papers, that's what you call your completed referral. So at the end of the month, for example, I have a list. I have daily numbers of those we're able to reach. I also have daily numbers of those who agreed. And then I also have daily numbers from the papers delivered at the facilities, those that eventually completed their referral. That's a lot of information. I can calculate a percentage of completed referral. I can say, okay, my intervention is successful because 50% of the people we reached agreed to go to the facility and collected our referral. And then 20% of those we eventually gave that sheet of paper, which is a referral, eventually completed their referrals at the facility. It's simple. Another way to do a non-expensive monitoring is if you layer on existing referral system. Some states have community referral systems, and you can also use that. So using existing data sources also makes it cheaper. Yes, thank you very much. I don't know if I've been able to answer your question.
Yes, you have, Ma. Thank you so much, Ma.
Okay, thank you so much. Please, would you like Professor Rosemary to share her knowledge on your question, because you addressed the question to her also. Professor Rosemary. Hello, Prof.
Yeah, thank you very much. I think the question has been thoroughly answered.
Okay.
It has. In reality, when you look at it, I said before, I said human resources is your greatest asset. You will never have enough money. Or it's not easy to always have all the funds you need. So there are ways of still achieving purposes. So you can still do your monitoring and evaluation, even when you don't have funds to employ an M&E officer. There are ways that I just explained all of them. Thank you.
Okay, thank you. Thank you so much, Prof. Please unmute yourself. Please mute yourself. Thank you. Thank you so much. So we'll be going to the next agenda of today. For today, we'll be going to the next presentation.
So I think somebody else's hand is up. I don't know if the person has a question. A certain Sebastian.
Okay. Yes. Okay, Sebastian. Please
okay,
ask
good
your
afternoon.
question.
Yeah, good afternoon. I just wanted to add to the responses from the presenters. What I've seen that has worked for small organizations that are challenged with personnel resources, to having an MRE officer as a separate office, is to train the existing project officer on rudiments of MRE. That works for small organizations. That will probably conserve resources, help the organization achieve their monitoring and the evaluation goals within the confinement of that program. So we may begin to consider that, let the project officers double in that capacity as against waiting when you have resources to recruit. Over.
So much. M1 Lagos, do you have any other thing to say? Do you have question or comments? I can see your hand raised up.
Hello. Hello, good afternoon. Hello. Hello, good afternoon.
Good afternoon.
Good afternoon, Ma.
Good afternoon, Ma. We can hear you.
Okay, my name is Dr. Mosoya. Thanks for the various presentations. I want to talk about the first presentation, or the second one, on Alimosho, in Alimosho local government. Can I ask, how does the use of infrastructure affect the access to PHC services? since infrastructure is one of the problems, there. Then again, I could remember that I was privileged to be one of these, people who set up the Alimosho PhD. And at that time, there were a lot of outreach systems put in place with University Community Health Department of LASU monitoring the whole system of maternal and child health. I don't know how this system has impacted on your results. Then the other question on the last one, that M&E. Most programs will want to develop M&E in programs, in designing their programs. But the problem we have is the implementation and the monitoring or the data, as you mentioned, analyzing the data and making use of the data, especially the feedback to the communities. I think we now have to ensure the utilization to be more prominent in our tracking the success of program. For instance, you mentioned about the insecticide distribution. When we were distributing insecticide at the time that we started rollback malaria, the politicians were taking the insect nets and distributing it to their political gurus. So I think not much is done on tracking the utilization of the nets so as to see the outcome of its effect on the success of the program. I think this will be very important. Thank you.
Okay, thank you so much. Thank you so much for that contribution. Any other contribution or comments or questions before we go to the next agenda?
I think she had a question for Dr. Borowa that presented, second presenter. I don't know if Dr. Borowa is still here with us, if she has a comment or two.
Okay.
Dr. Borowa, are you still here with us? Okay. She's not here at the moment, but I would definitely get in touch with her. She's at work anyways.
Okay, she's here. She's here.
Hello, I'm here.
Okay.
To unmute myself.
You said you will leave your money.
Hello?
We can hear you.
We can hear you.
Hello?
Hello, good afternoon. Hello, good afternoon. I'm Mrs. Akinremi. Hello, good afternoon. Hello?
You.
Sorry, please, the line is breaking. Maybe we continue, then later on we can all get to the question and answer.
Hello? Hello?
Okay. Hello, ma. We can hear you, ma.
Hello,
good afternoon.
We can hear you.
I'm Mrs. Akinremi from Adodota local government. Thank you very much. I appreciate the several hands and other professors that has been speaking. The concern this improved maternal health. What I want to say, the issue of this brain drain and shortage of staff. Please, the organization should help us talk to the government, consign the employment of people so that we can move forward than this. Thank you very much.
Thank you, ma. So I think we can move on to the next agenda. Or is there any other question or contribution?
Yes, I think we move on. I will revert to Dr. Borowa. Thank you.
Okay, thank you so much. Okay, so we're going to the next presentation, which will be taken by Taiwo Oluwadamilola. Factors affecting should be taking us on factors affecting access services in a rural community, North Central Nigeria. Taiwo Oluwadamilola. Are you ready? Taiwo Oluwadamilola.
I'm here, ma. Good afternoon.
Good afternoon.
I'm here, ma. Your end.
Sorry, I did not hear that.
I sent my slide in to the email. SHI email.
Okay, I thought you have been able to, you were able to share it with us. Okay.
Then someone else to share. This is not me.
Okay, let's move.
There's someone else sharing this screen, right? Hello, ma.
Yes, I can hear you. You said your line is breaking. You said what? Sorry.
Oh.
You said your I can't clearly hear you.
Ms. Damilola, your line is terribly breaking. So what we'll do now is, while we try to allow you search your internet and all of those, I think we can move on to the next session. Then maybe after the panel session, you would have been able to sort the your network and presentation issue so that we do not waste time. So thank you. So
okay.
Ms. Chinonso, I think we can move on to the next thing. Then after the panel session, then we can continue to Mr. Amidola's presentation.
Okay, thank you so much. So we are going on to the next agenda of today. I'll call on my co-moderator, Dr. Ogenekume Aga, to anchor that. Dr. Ogenekume, are you available? Dr. Ogenekume. Dr. Ogenekume, can you hear me? Dr. Ogene.
Good afternoon.
Okay. Afternoon, welcome.
Good afternoon. All right, standing on existing protocol, we'll be moving on to our next session now. And we'll be having Dr. Ngozi Obi, who is a consultant obstetrician and gynecologist. She'll be joining us for the panel session. So she's a consultant obstetrician and gynecologist who is currently working at the Ambassador Clinic on Baledi, Lagos. She's also a fellow of the West African College of Surgeons, the Faculty of Obstetrics and Gynecology. She has been working in the Department of Obstetrics and Gynecology of several hospitals in Nigeria since 1998. After a national youth service, she worked at Bauchi Specialist Hospital, which is now Abubakar Tafawa Balewa Teaching Hospital, for 7 years, and worked at the Lagos State University Teaching Hospital for 5 years. Lagos Island Maternity Hospital, New Merit Hospital, and ML Hospital, Lagos State. She's experienced in the management of obstetrics and gynecological condition, and also experienced in obstetric and gynecological surgeries. Thank you, Dr. Ngozi Obi, for joining us today. The next person we'll be having is Professor Adebukola Adefule Oshitelu, who is a renowned ophthalmologist, professor, an educator, and an activist. She is also the chairman of the Lagos State Traditional Medicine Board. She has vast expertise in the domains of education and research and professor of ophthalmology at the Lagos University Teaching Hospital with numerous publications. She also discovered the importance of polar-based eye drops for glaucoma, which has been approved and registered by organizations such as the NAFDAC. Academic training has given her a critical view on the function of traditional medicine in modern healthcare systems. She has been a key player in the creation of educational programs that encourage the merging of traditional medicine. Orthodox medicine. Professor Adelaide. Hello. Can we hear me?
Yes, we can, please.
Oh, so sorry about the breaking transmission. Hello?
Hello, we can hear you, my darling.
Okay, all right. So, thank you, Professor Adefule Oshitelu, for joining us today. We really appreciate your presence, ma. Moving on, we move to Barrister Ayo Adebusoye. Barrister Ayo Adebusoye is a senior attorney and leading development expert and social entrepreneur with multidisciplinary experience in the faith-based, social, public, and private sectors. He has an international working background of networking and partnering with diverse organizations and groups. He's experienced in coordinating state and national level advocacy campaigns, as well as proficiency in programs conceptualization, health budget policy analysis, monitoring, and evaluation systems. He has been engaged and recognized internationally since 2009 to date as a partner NGO legal expert with the International Center for Nonprofit Law, Washington, D.C., USA, and as a country expert on philanthropy by the Hudson Institute, USA, at the subnational level as a practitioner, lead researcher, assessing the roles and impacts of the third sector in Lagos State. He has served as the Secretary General of the Nigerian Network of NGOs, co-founder, Chairman, Board of Trustees in the Lagos State Civil Society, Chairman, Public Health Sustainable Advocacy Initiative, co-chairman, Lagos State Accountability Mechanism for Maternal and Newborn Child Health, Technical Advisory Committee member, Performance Monitoring for Action in Lagos State, Trustees and National Secretary, Public Procurement Observation and Advocacy Initiative, amongst other numerous responsibilities. He has previously served as a pioneer member of the governing board of the Lagos State Public Procurement Agency and has been recently appointed in January 2020 to the governing. He's also in research with vast publications. Thank you, Barrister Adebusoye Ayodele Adebisi, for joining us today. And lastly, we'll be having Comrade Olurotimi Julius Awojide, who is a nurse administrator, midwife, and is joining on behalf of the National Association of Nursing and Midwives of Nigeria. He attended Obafemi Awolowo University Teaching Hospital in Ile-Ife, graduated as a professional nurse in year 1989. He worked for some years in private hospitals before returning to study a Bachelor of Nursing Science degree at the Premier University of Ibadan. While studying for his Bachelor of Nursing Science degree, he fought for the inclusion of males in the midwifery profession and eventually became the first male midwife from his geopolitical zone. He also obtained a Master's of Science degree from the University of Ibadan with specialization in maternal and child health nursing. Presently, Comrade Awojide is a Deputy Director of Nursing Services with General Hospital Lagos. Comrade Awojide has also held many leadership positions, some of which include the Secretary Nursing Student Association of the Obafemi Awolowo University Teaching Hospital in Ile-Ife, President National University Nursing Student Association, University of Ibadan Chapter, State Chairman, National Association of Nigerian Nurses and Midwives, Lagos State Council, State Chairman, Joint Health Sector Union, Lagos State Chapter, State Auditor, Nigeria Labour Congress, Lagos State Council, State Treasurer of the Public Service Joint Negotiating Council. Also, board member of the Lagos State Health Maintenance Agency and board member of the Lagos State Health Facilities Monitoring and Accreditation Agency. Comrade Awojide is happily married and blessed with children. I present to you today our panelists for the panel discussion. Thank you.
Thank you very much, Dr. Kome, for that beautiful presentation, introduction and citation of our panelists, so that we are right on track. I would like for our panelists to kindly unmute themselves as we begin to discuss the question. So I would start first from Dr. Ngozi Obi, who is representing the Society of Gynecology and Obstetrics of Nigeria. And my question to her is, can monitoring and evaluation be integrated into leadership strategies to improve maternal health outcome and its sustainability? Because we find that till today, they still say, oh, doctors are still the maybe team head or the head of the healthcare team, and that. So do you think that M&E should be integrated into leadership strategies?
Good afternoon, everybody. Thank you for inviting me here. Stand on non-existing protocols. Well, yes, I think monitoring and evaluation is important, needs to be implemented into leadership strategies. Why? Because one, monitoring, what is monitoring? Monitoring is assessing the processes you have put in place. You assess the processes, you put some processes in place, you're assessing them, you assess them to see whether they're working or not. And then evaluation is, you want to see the outcome you have achieved, if that was what you planned to achieve when you started the program. So there's this help. So it's important. So they are important when you want to determine whether improving the strategies you put in place to improve maternal health outcomes are sustainable. Because the data you get will help you to know whether this program you put in whether it's working or not, and whether there's any point continuing with the program or putting new measures in, other additional measures in that would help to improve the success of the program. Thank you.
Thank you very much, ma'am. So our next question will be going to the first the first man that will be speaking with us today. That is Barrister Ayo, who is representing the Nigerian network of NGOs. And the question to him will be, how can NGOs and program coordinator use M&E data to inform decision-making, accountability, and improve effectiveness of maternal health programs. Knowing that we have learned today that, monitoring and evaluation is important, it means you have to routinely collect data. And like Dr. Mosonya said, that sometimes it's not like people don't collect data, but they don't use it well, they don't collect it, they don't send it back for feedback. So how can we, in general, product coordinators, NGOs, organizations, how can we evaluate and use the data to make informed decision, accountability, and improve effectiveness, sir? Thank you.
Thank you very much. I think that's basically why the experience we've had in Lagos State. Can you hear me? In Lagos State,
yes, sir.
The experience we had with the Lagos State Accountability Mechanism on Maternal, Newborn Child Health and LACSAM was actually just that, was to really ensure that we monitor, we review, and then we act. Basically, that's the whole methodology which we use, where society, governments come together to ensure that data from routine data that is being harnessed at the facilities come in, they're evaluated, they're analyzed, and they are now used for advocacy. So one of the things that brings up and brought up in Lagos over the years was that where there were gaps with regards to data collection, they had to really up their game, because regularly every quarter they knew that they would have to be made to account, where all the M&E officers, etc., and the local government have to ensure that the data are proper. And once there were gaps in that, it shows up, in terms of the scorecard. And that's why it's really important to track all these kind of data on a regular basis, so that, and especially rank them. So by the time you're seeing your local government with red everywhere, and there's going to be trouble, your local government chairman will say, what's happening? So one of the things which we've found is the importance of having timely data. And that's why the aspect of having transparency with regards to our budgeting system, because when we're talking about data, it all comes down again to how much value for money, how much is being tracked from the inputs, resources, budget, to utilization, to the facility level, and to the beneficiary. So one of the things we really, which is coming up clearly in Lagos, and Lagos, you can imagine 20-something million, 27.8 million odd, dealing with that population. They really have to be on top of their game with regards to ensuring that data is coming. And of course, one of the challenges we have, of course, in Lagos, is that we have so many facilities that are even outside the Lagos State government's control, so to speak. We have various military hospitals, police hospitals, tertiary hospital, Luth is there, others which are out of, and these are all still captured under Lagos State. And so it's so important, and this has been one of our advocacy asks, to try and ensure we get all this data together to be able to really have an accurate picture of what's on ground. One of the things, the research, very interesting research that was done in Alimosho, came up to show that, in fact, one of the main things, even at the PHC level, that's discouraging people is the perceived costs of services. So if the PHC is even having that perception with regards to the persons, those who should come up, patients. So imagine at the secondary level and tertiary level. And this is why it's very important that this kind of data is harnessed and put into government's planning to ensure, for instance, that one where we see that 30-something% of the respondents said that it's an issue for them. The main issue is the cost at the private healthcare level, which should be very cheap. Shows the importance of why we need to really emphasize the aspect of health insurance, Illyria Eco, and push that forward. So this is how you can get data and use it for your policy decisions. Thank you.
Thank you very much, sir. And we hope that this plan by Lagos for health insurance and advocacy, we are all able to key into it. So moving on to the next question. This question will be directed to Professor Oshitelu. She has been one of the fire fronts at the front of inclusion of community birth attendants and other community healthcare providers into formal healthcare delivery. So, Ma, what ways can effective partnership between governments, because you are at that intercept of government, community organizations, non-governmental organizations, and other stakeholders, what are the effective ways that they can partner to leverage and ensure proper dissemination of information among themselves? Because like I said, a lot of organizations, they do a lot of things, but they are all in silos. So what effective ways do you think that both the government, the community, healthcare providers, stakeholders can all partner to ensure that there is dissemination of information that are gotten from maybe M&E or whatever intervention they do to improve maternal health programs, Ma?
This is to me.
Yes, Ma.
Question is to me.
Yes,
Professor
Ma.
Shitelu, right?
Yes, Ma.
Yeah. Good afternoon, everybody. I must
Good
commend you
afternoon,
for
Ma.
this particular program. And yeah, can you hear me? Hello,
Yes, Ma.
can you hear me? Yes.
Yes,
I
Ma.
say I commend you all, and I'm greeting everybody. Please, the protocol. I stand on the existing protocol. Now, one thing we need to realize is that most of the stakeholders are not literate. And we need to put this into consideration. The Traditional Medicine Board is doing a lot in collaborating with all the MDAs and all the hospitals. And what we have discovered is that data meant nothing to them until we started to emphasize. And one thing again is that we need collaboration from you and also the government. And then the stakeholders, that is the recipients. What we are planning is to include and advocacy. You need to sensitize them, and then you need to train them. The sensitization and advocacy we started in the Bilevash, way. That is the 5 sections of Lagos State. We go from one zone to the other. And what we have discovered, and it's becoming very effective, is that we make sure that we get their obas, their leaders, their ballets involved. So the people in their area, in their community, they are gathered together, and then we sensitize them, we advise them. We make sure that they are not supposed to practice unless they are registered. And from there, they must belong to an association. It is regularly every month. And it is at that meeting, they now do collation of all the data. They've been encouraged that anybody they see, every patient that comes is registered. They must have the demographic, features of everybody. So that has improved. And now it's even going to be more important that we have so many of our doctors and, medical people, exiting the country. So, and they cannot exit anywhere. So we need to make use of them because we want to make sure that mortality and morbidity are brought to 0 level. And so a lot is being done. And please, we need to let you know that wherever you want to go, make sure that the board is aware. And at least one person will be there when you are meeting with these people. It's okay when you have, gatherings and you speak with them, you distribute this, you distribute that. Most of them should be done with the knowledge and, presence, attendance of the board, so that they can help you to monitor this very well. It's already taken a positive effect. Then we noticed that the mortality and morbidity is much lower than what it was before, because we've been able to do monitoring, serious monitoring of all of them that are registered. And we discovered that it is the auxiliary nurses that are trained by the orthodox doctors that are committing more of this crime. And with the help of Pharma, we've been able to make sure that, we're curbing this. No auxiliary nurse should open any clinic or practice because they're not doing the proper thing. Apart from not doing the proper thing, they are not keeping data. They must keep the data. So they must belong to the orthodox, that is the Pharma group, unlike the Lagos medicine, but that is traditional and it's now being combined with complementary and alternative, but the major thing is that we need to all sit together, please. There must be one or two, gathering of all of us to sit down and really fashion out how we can totally have effective morbidity and mortality we can have with our people. It's okay, we really appreciate because the government are contributing immensely. Let's all collaborate. Let's work together so that we can have, the best results that, we actually are aiming at. So please, you are doing well, but let's improve on the collaboration. And
thank you very much, Ma.
All right. Okay.
Thank you so much, Ma. Thank you so much, Ma, for that lucid explanation of how the Medicine Board has been able to, monitor the actions and the improvements of the services provided by our medical practitioners, practitioner healthcare providers. I would like to direct the next question to the representative of the Lagos State Primary Healthcare Board that is with us. So now that we've heard what Professor said about, leveraging on boards and ensuring collaboration, carrying along stakeholders, both the literate and the non-literate, how do we overcome the challenges that organizations face in disseminating their results to these bodies, that are involved in implementing policy? For example, now, I work with a non-governmental organization. We've been doing intervention, we've been collating data, we've been analyzing them, but we've not really seen anywhere or any call from any of these policy-making bodies, maybe like the Federal Ministry of Health or the Primary Healthcare Board, that is calling for us to, submit our data or bring our results. So how do we overcome these challenges, and what are the solutions that can be preferred?
Okay, good afternoon, everyone. Can you hear me?
Yes, Ma, we can hear you, Ma.
Yeah, my name is Dr. Basoya Adiola. I'm a program officer at the Lagos State Primary Healthcare Board. Okay, so based on what you said, I think there's a system on ground for collaboration and partnership. So for you to enter into any community in the first place, there must be community entry. You must meet with the stakeholders, the community stakeholders. That includes the Lagos State Ministry of Health and especially the Lagos State Primary Healthcare Board. There's something called an onboarding meeting where you would meet with whoever program officer that you want to work with to discuss the program. And they would guide you through how you go about the program, and also in the aspect of data collection, monitoring, and evaluation of the program. So I think the problem that we usually face is that partners just go into the community without informing the board of their activities. And I will think that for every activity that any NGO, any organization is going to perform, especially when it has to do with the community, it is best that you present it or you discuss it at the board level, so we'll be able to direct and plan, even with such partner, we'll be able to plan and look at the program and even see how it fits into the state's strategic health plans. You understand? So, and also, we'll also get involved in the monitoring, collation of data. We want to know what is happening in the state. So whoever is doing the program without the state knowledge, we don't encourage such. Thank you.
Okay, thank you, Ma. So from what you just said, so organizations doing any community intervention should just ensure that they inform the board first of their programs, and when they are done, they send in the results.
Yes. So there is something, okay, when you come in, we want to know what the program is about. They want to check, there's something called a baseline data survey, which is essential. We want to see the reason why the program is even going to be effective in the first place. What if there is no need for the program? Because a lot of people, a lot of organizations coming in with different programs, for some may be beneficial to the state, some the states already have in place. So those are the things that we will look at to assess the effectiveness or the outcome of such programs. And when we look at it, we're able to see, okay, then when you conduct the baseline survey, that will help us to know the importance of that program. Then we'll be able to monitor from that baseline. Okay, even after the program, we'll see whether it actually was able to. So that is the monitoring and evaluation thing coming in place now, whether the program made a positive outcome or just it didn't even do anything. So those are the things that we look into as board members and as program about to occur in the community. Thank you.
All right, Ma. Thank you so much, Ma. Thank you very much, Ma. So our final question goes to the second man on our panel again. I don't know if he's available. That is a representative of National Association of Nigerian Nurses and Midwives. So to the representative that is representing the NANNM, a final question will be, as nurses and midwives who are actually at the forefront of maternal health care, you know, you cannot talk of maternal health care and not talk about the midwives and the nurses. You know, they're like 90% into it. So what are some of the key indicators that you think people or stakeholders should look out for, or indicators that, you know, should be at the forefront of the monitoring and evaluation of the impact of their programs? Thank you.
Yeah, thank you very much. And I want to appreciate the organizer for inviting me to this program. As nurses and midwives, like you said, we are actively involved in maternal care. And to know the effectiveness of the monitoring and evaluation program, we need to start from the antenatal clinic. How many of our pregnant women are actually accessing our healthcare facilities for antenatal care? And how many of them, after registering for antenatal care, how many of them are actually coming back to deliver in the health facility? Because we have seen cases whereby we have many people registering for antenatal care, many people coming for antenatal care, but when you take the statistics of how many of them actually deliver in that health facility, is you know, if I cry from the number that have been coming for antenatal care. Then we also want to know maternal deaths. We want to know the maternal deaths in the hospital. What are the causes? How can we really intervene to reduce that? So also want to know the number of skilled birth attendants that are actually available in our healthcare facilities
to attend to pregnant women. As we said, the brain drain is on the high side now, and the workload is getting too much. And we know that when an health care practitioner is overwhelmed, overworked, it has direct impact on the health of the woman. It can have negative impacts on the health of the woman, and the care outcome can be negatively impaired. So we need to know this, that we have enough healthcare practitioners to actually take care of our women. We also need to know are the equipment needed to care for the women, are they readily available? Can the midwives or the ski bath attendant, can they actually monitor the progress of pregnancy, the progress of labor properly with adequate equipment? Are all these things available? If they are not available, definitely we should know that there will be also negative effects on the outcome. So, and we also need to take note of the political issue that has been mentioned. In my interaction with the Primary Healthcare Board, I discovered that Primary Healthcare Board, despite their efforts, they are not in total control of the health centers. You see the chairman of local governments dragging the ownership with the Primary Healthcare Board and impacting on the effective management of our healthcare facilities. And that has been really disturbing, in that things that should be resolved at the primary healthcare level, you see the chairman, putting stumbling block on the way. And this is an area that should be looked into properly. Maybe the government need to look into the law and see how the health facilities can be probably put totally under the control of the Primary Healthcare Board. So this area also needs to be looked into. Also of importance is the policies that we have on ground in our health facilities. What are the policies? Do we have standard operating procedure that people need to follow to guide them properly? All these things will also be of help if we are able to put them in place. And it's also very important for us to make this monitoring evaluation sort of make it mandatory, because like nurses and midwives, we have access to so many information that probably we are overlooking, we are not reporting, we are not seen as necessary for the improvement of the facility. And the need for nurses, midwives, and other healthcare professionals to be actively involved in data gathering, in research work, is very, very key. We have a lot. Hello?
We can hear you, sir. Okay,
so we have a lot to gain when all of us are actively involved in this monitoring and evaluation, because for now, it's not everybody that I will say is actively involved. And like I said, it's a teamwork, and we need to really, when you see something, say something, write something. So we need to all be involved so that we can improve the healthcare services in the state. Also, I've discovered that in the past, the home visit used to be a very, very important aspect of our care. But nowadays, I don't think home visits is there again. Are we going back? How can we go back to that, so that home visit can be part of the care or the services that we are rendering? This is something again that we need to look into. and the skills of healthcare practitioners. Many of them are not well skilled, especially when you talk of emergency obstetric care. This aspect is not everybody that is well equipped, and this is necessary. If we must arrest complication, we must arrest serious issue on time. People that are attending, the first responder, must be skilled enough to do something that will actually rescue the woman. So we need to also look into this area, that training and retraining of healthcare workers is very, very important for them to be well equipped in life-saving skills. So I think we also need to look into like the Ondo experience during Governor Mimiko. He engaged with the traditional medicine board, and what he did that time was to give them incentives, to even encourage them. When you see a client, bring them to a center, bring them to a healthcare facility, we will give you so amount for referring, instead of even them taking the delivery and bringing when they notice complication. And that really make Ondo State to be at the maybe #1 at that time with good health indices. So we need to look into so many areas of care, so that to make sure we improve on the services that we are renting and reduce maternal mortality in our society.
Thank you very much, sir. You are really giving a whole lot of points. Thank you so much to all our panelists. Thank you to Professor Oshiteluma. Thank you to Barrister Ayo. Thank you to Dr. Ngozi. Dr. Ngozi was the first person to join this meeting today. And thank you to Comrade Awojide. And thank you to our PHCB representative, that is Dr. Obasonya. Thank you so much for making our time to join us on this panel. So I don't know if anybody has any quick question for anybody on the panel before we take our last abstract presentation for the day. Okay, so in the absence of any question, I don't know if Ms. Damilola Taiwo is ready to take a presentation.
Yes, I am. Good afternoon, ma. Okay, Ms. Damilola, you can go ahead with your presentation. All right, can you hear me clearly now, ma? Yes, we can hear you. Okay, thank you very much. Thank you very much for the opportunity. I really appreciate. Standing on an existing protocol, I'm the founder of Pouring Out Health Equity Initiative. And in our NGO, what we do is that we reach out to rural communities, we identify their health needs, and we meet the health needs per time using innovative ideas and systems. So from last year, we commenced a project called Community Outreach on Pillars of Safe Motherhood to communities, and we carry out community diagnosis, identify the health need they have amongst the 6 pillars of safe motherhood, collect data from it, and then try to create a system that we can implement to meet that health need. So we visited one community in North Central Nigeria, precisely Kwara State, Ijomoro in Kwara State. And we worked on the community diagnosis. Actually is poor use of health facilities for both antenatal care, obstetric care, and early newborn care. So the work we did is on factors affecting access and utilization of health services in that particular community. So for our background study, although Nigeria represents only 2.4% of the world's population, it currently contributes 10% of global maternal mortality. And the reason for such maternal mortality rate has been attributed to several causes, which include lack of access and non-utilization or underutilization of maternal health care services. So this study aimed to determine various factors that affect access and utilization of maternal health care services in rural community in Kwara State. So our objectives were to evaluate the ease of access to maternal healthcare services in the rural community, and also to investigate the factors that determine the choice of health services used by women in the community. For our methodology, we had a descriptive cross-sectional study conducted among the women of reproductive age group in the community. Then we used semi-structured interview administered questionnaires to collect data. And the data we collected was analyzed using chi-square and the level of significance set at 0.05, while qualitative data were analyzed thematically. So from the results that we got, the median age of our respondents was 30 years. Now, 59.6% of the women visited TBA, 21.9% visited PHC, that's primary healthcare center, nearest to the community, while 18.5% were assisted by their relatives. So we tried to assess what health facility have you been using, that's amongst the women, for both for your antenatal care, for your delivery, and even after your delivery. And even in case you had any emergency, maybe for yourself, for your at any facility, or you're attending the TBA, or you're at home taken care of by a relative. So this gave us data that 59.6% of them used the TBA, 21.9% visited the PHC, and 18.5% were taken care of by their relatives. Now, the reasons that they gave, 55.8% complained of long distance to the PHC, 44.2% complained of high cost of care. For selected community to visit, the community has either one or less than one, that's zero healthcare facility available. So we visited communities that were totally unreached and had no healthcare facility. And we tried to assess, is it that even for those that have any facility at all, you use, and even though you have, you try to assess anyone. So what we got was that 5.8% complained of long distance to the PHC, and 44.2% complained of high cost of care. Now, we realized that for them to get to the health facility, that's the PHC available in the community, they have just one PHC available. It actually takes 2 hours to get to the PHC available from where the respondent actually stayed. It took them 2 hours to get to the PHC. Now, some of them say they took a bike, and it took them 45.7% took a bike and took them 30 minutes to get to the PHC, while 38% have to get to the PHC by foot. So this is actually the reason why they don't make use of any health facility available. So this is a pie chart showing us sources of healthcare available, 59.6% using family and female leaders, 21% using government facilities as the PHC. Then this pie chart shows the factors that affect the choice of healthcare service used. 44.2%, they complain about the fact that treatment is costly, while 55.8%, that's actually majority of the women, complained of long distance. The conclusion we derive from this is that amongst the several factors that affect access and utilization of maternal health service in this particular community, long distance and the high cost of care is significant. And this can be said to account for the percentage of women who do not visit the PHC facility. So our recommendation is this, is that there is actually a need to identify the health need of each community, and not just to have a one rule fits all rule for implementing healthcare systems or healthcare programs. We need to identify each community and know what exactly is the need you are having, and how can we create a system or a structure that can address the need of this specific community. So that's the recommendation we have, and there's a need for robust and stepwise intervention strategies that improve maternal health care. Thank you very much.
Okay, thank you so much. Thank you so much for that presentation. Taiwo Oluwadamilola, thank you so much for that presentation. Okay, so we're going to our next agenda for today. We're going to, I want to call on closing remark. I would like M1 National YDF Coordinator, Dr. Dorcas Saiwu Ola, to give us the closing remark. Dr. Dorcas Saiwu Ola, please, are you available?
Good afternoon, everybody. She actually she had to leave the meeting earlier because they had some official impromptu meeting she had to attend to with the governing body of the teaching hospital where she works. So I'll be giving the remarks on her behalf. Once more, I really want to appreciate everybody that made our time to be a part of this summit today. In as much as we wanted it to be a physical summit, but due to logistics beyond our control, we were able to only make it virtual. And even from the beginning till the end, we had people still stay with us. I really want to appreciate us. I want to appreciate M1 Lagos presidents, M1 Lagos executives, and all our panelists, the representative of Sogon, Dr. Ngozi, representative of NNGO, Barrister Ayo, the representative of NANNM, Comrade Awojide, the representative of the Primary Healthcare Board, Dr. Obasanya, the representative of the Lagos State Tribal Medicine Board. She has really been helpful in most of our programs in trying to train the TBAs as well. That is Professor Oshitelu. Thank you so much, them, and our amazing speakers of the day, Professor Rosemary Ogu and Dr. Donyo. Thank you so much for the lucid presentation and thoughts you have given to us today. So in just a short summary, some of the key takeaway from today is that monitoring and evaluation is important, and for us to move ahead with our healthcare interventions, we have to ensure that they are done and that it should be included at the beginning of the design of our intervention. That way, it's not an afterthought. As well, there are non-expensive ways to do M&E, although sometimes it's about collecting data, but some of the non-expensive ways that some of our speakers and contributions from our participants were able to give us is we should use the reach method that Dr. Odoye said. So number of people reached, number of people that access the services, whatever service it was, a number of people that actually picked it up. Those are simple ways that you can, conduct M&E. Then also leveraging on existing data, and another participant also gave us the idea of leveraging on the available personnel. So if you cannot afford to maybe hire a M&E officer, you can train your program officer or project officer on how to do M&E. So those are non-expensive way of ensuring that M&E is done. And Dr. Mosoya also mentioned that some people actually collect data, but they don't synthesize the data. And we all should ensure that whatever data we collect while doing our programs are actually synthesized and sent back as a form of reports or results to, governing bodies for policy implementation and decision making. Like some of our panelists said, Dr. Obasanya, representing the PHC board, explained that for you to do an intervention, have results, is always nice to send it to the board as a form of collaboration, which was also emphasized by Professor Oshitelu. And Barrister Ayo spoke about advocacy and health financing, as well as sensitization. And, they also mentioned that most of our stakeholders are not literate. So we must always learn to put that at the back of our mind in whatever intervention and whatever monitoring and evaluation process we want to do. And also always leverage on existing boards and collaboration to ensure that our intervention actually effective, and whatever results we get, whatever data we get are actually utilized properly. And also somebody mentioned that some of the challenges that have been faced is that some of the most harm is being caused by those auxiliary nurses that are trained by orthodox doctors that are just out there functioning on their own, but FEMA has been able to help to ensure that that is being copped, and also there are systems on ground to ensure that there are collaborations, and we should always ensure that we have a baseline data survey. And also Comrade Awojide went on to really emphasize on some of the key indicators that we could use, like monitoring women that actually access antenatal care, women that actually access postnatal care, women that although they enroll for ANC, but how many of them actually deliver at the facility. And also it talked about the bureaucracy in the ownership of PHC between the local government and the primary healthcare board. And he raised, a suggestion on how both can either be synergized to be able to work with the PHCs together. Then also he mentioned on the possibility of home care services, the reintroduction of home care services for women, pregnant women, and newborn, and also the training and the retraining of healthcare providers, be it skilled or the unskilled, because this helps to ensure that they are up to date as first responders with the necessary skills needed to ensure that all complications are resolved. Also, he mentioned on the part of incentivizing referral from the community, either from community healthcare workers or from the TBAs, as that also helps to ensure that the pool of people accessing maternal health is being directed to proper healthcare facility. So that is like a short repertoire of everything that's been said. The presentation by our speakers has been sent, and we'll try to ensure that we send it to our emails. So this is 3:30. Permits me to just take 5 more minutes of our time, because I know we were supposed to have finished by 3:30, so 5 more minutes. So this is a call to commitment, and how we do that is that if you're on this call, you are a stakeholder, you belong to an organization, kindly drop your commitments in the chat box with your name, your organization, your designation, and your email, so that we can collate this and send you further actions from now, and we can kind of like have a pool of resources to always leverage on. So that is our call for commitment today. Like Professor Rosemary said, wherever you are, you can always do something. It doesn't have to be highfalutin thing. Even if it's in your community, if it's on your street, you can always make an intervention, but ensure that it is effective and ensure that you are monitoring those things routinely. So I don't know if anybody has any question or any clarifications or suggestions or anything before I call. I don't know if Madam President, the M1 Lagos President, is still on this call, so that she can just give the vote of thanks and we can call it a day. Any question? Okay, so I think the founder has been able to join us. That is Dr. Roland Ojo has been able to join the call. That's the founder and executive director of Safer Hands Health Initiative. Would you want to, sir, would you please unmute yourself and just give the vote of thanks, please? Dr. Roland Ojo.
With you. Hi, everyone. Good afternoon. Thank you very much for joining us today. It's been a very long afternoon of very detailed conversations, and I've been able to learn so much from, and even gain so much experiences that are very invaluable. For all our presenters today who presented major topics, research topics that they've been involved in, we really, really appreciate you. We thank you very much. We are hoping that beyond the presentation here that you've done, we're hoping that you would go much more to push this to the world, because the 4 topics that have been presented today are very important. There are things that affect Nigeria so much utilization of the healthcare services? Is there access to maternal health, for which Safer Hands itself was founded on, and a lot of other major topics that we've talked about today. We hope that we will not just do this and just keep them in the box. We hope that we're going to push this. We're going to even publish it in more big journals, and then that information about our own healthcare would be seen all over the world. And we thank you very much for all our presenters and our guests today. We really appreciate you for everything, for all the conversations that we've had. Like Dr. Agoye has mentioned, we're still looking forward to working more with you, and then we'll be able to meet up in further time. Thank you very much for your time.
Thank you so much, Dr. Roland. So just before we go, I don't know if we've been able to take pictures. Again, once more, we want to apologize that this meeting could not be done, this summit could not be done physically. We really tried to make it possible as a physical summit. I even got some call this morning that some of our participants had gotten to the venue. We had to start sending apologies to them. We hope that by next year, with collaboration amongst us all, amongst the board, partners, and all of us, and using this summit as like a point of dissemination, the way we're able to come together today now and share what we do in our various fields, share information, learn one or two things. We hope that we are able to, make this bigger next year. And also, like Dr. Roland just said, in SHI, we, beyond just doing the summit, we have our community outreaches that we do to antenatal clinics, we do to primary healthcare centers, and we also train traditional birth attendants. So if we reach out to you in the nearest future, to collaborate on these things, to bring the program to your community, you would not turn us down. Once again, thank you to everybody that's been on this call. We really appreciate. And like I said, let's ensure to drop our name, our designation, our organization into an email, into the chat box, so that, we can be collated for future references. It's been a wonderful afternoon. And like I said, 5 minutes extra. This is 3:35. If we have any questions, let us know. Any suggestions, let us know. You can follow us on our social media. You can follow us on our social media, and follow our works as well: Facebook, Instagram, Twitter, and everything. Over to you, Chinonso.
Thank you, everyone. Dr. Kemi have said all. So, like she said, the slides will be shared to all the participants and anybody interested in getting the slide via email. Kindly drop your email in the chat box.
Please, can somebody take pictures for us so that we have pictures to show, even though we are not present physically? Can we all turn on our videos and, take pictures, please?
Okay.
Let's turn on our videos. Oh my God. So I've been talking to So I've been talking without my video on since. Didn't know.
Thank you, everybody.
Anyways, okay. Thank you, Mas. I'm waiting for us all to turn on our videos.
We will see more positive results of what we are doing. God bless us all.
Amen, Ma. Who's taking the pictures for us, please? Okay. Some people are not seated yet, or are they standing? So at least we have it on yeah. Thank you, guys.
Participants.
Yes, please.
Well done, everyone. Are we free now?
Please, for the camera. Yep. Somebody's texting. Stop texting so I can take people's picture.
Okay, cheers for the camera. Thank you very much. Thank you so much. So we'll send the presentations to our emails, and really we have over 40 people here till the end. It must have really been a serious thing people are learning. For us to have this much people till the end. Thank you so much, guys. You can leave the meeting now. Chinon, so please, can you help me collect the emails, all the names, the introduction in the